no more hydroxyl group. It's hydrophobic now, wants to be in the core of large HDL. That's what happens. Cholesterol ester transfer protein then sends the ester over to acceptor lipoproteins, which eventually wind up in liver. That's how we get rid of cholesterol in excess. This has to function, or you're in trouble. And so, but we're able to measure this now. This can be done in cultured cells. It's very time-consuming and problematical, but this tells virtually the whole story. And we've got this to a point UC has a patent on it, and it's going to probably be used as a clinical measurement the cardiologist can ask for. So watch for 3-beta-1 HDL. And as we told you, that endotoxins are sequestered by triglyceride-rich lipoproteins. So we've got a lot of interactions here to think about. And but along with the complexity comes understanding. And so I think we're stepping into a new set of concepts here. Think 3 spaces. Think atherogenic lipoproteins. Think inflammation, really different zone, right? 65 cytokines. Think efflux, because these are the 3 big spaces that we're thinking about now. And I think it's a whole new mechanistic way of looking at what we're all concerned with diagnosing. And these interact with other diseases as well as vascular diseases, nephrosis, and so on. But the more we understand at the molecular level, the more we're going to have that we can actually measure. Is that yours?
We have time for some questions, Doctor.
Yeah.
I think Dr. Kaplan had a
I'm
question.
just curious, you sort of got my attention with this suggestion
Good.
that maybe if we're overly aggressive about managing LDL cholesterol, that there could be consequences. And if you look at the big trials, so the 4A trial and then the Improve It trial, there are reductions in events, but actually if you look at mortality, there's nothing there in either of those trials.
Well, I think that in general, probably statistically, we're eventually going to have to figure a level, a target level that's okay. And it may be in a patient who has tendency to sepsis because of the staphylococcus thing and the endotoxins and all that. We've got to be more cautious, and maybe somebody else not. Probably be highly individualized medicine, and we'll be looking at genes and various protein markers and so on, cytokines, to make these decisions. I think it's going to be very much more sophisticated kind of decision making, individualized. But you've got a point.
I mean, it almost seems, Robert, because no one knows what this level should be. I mean, the LDL level.
Yeah.
And the other thing that the Europeans say, it's a big meeting, 32,000 cardiologists. They seem to be comfortable saying, whatever your baseline LDL is, drop it by 50%. So, and establish that a 50% drop based on the outcomes trials is associated with X sort of reduction in MIs and strokes and events. But the absolute number, I mean, Odyssey and Florian, well, you're right. They showed relative risk reductions in heart attack, stroke, relapse, but they didn't show a reduction. In fact, they didn't even show a reduction in CHD mortality, never mind total mortality.
Your colleague Rita Redberg sent me this piece that she had done, commenting on a paper in her journal from Israel, where they look at, it's observational data, but they show that if you lower your LDL cholesterol down to 100 or so, then there's continuous benefit. But going much below 100 doesn't make that much difference. It's a huge corporate part of.
There are a lot of data that contravene that. I think that the PCSK9 data, for instance, but we have to get the individual context before we really know, because in one person it may mean more than mean something different than another. Because we're a pretty complex organism, We've got, 65,000 proteins that we make, and, so I think it's kind of brash to think that such simplistic analyses are really the whole story. So, but we're also finding how many apolipoproteins. We're down to MNO, somewhere there now. And we think but we've been doing mass spec and other colleagues of ours, we think there are almost 100 proteins in HDL. So, some of those are probably keeping us alive. What organism, I don't know, tuberculosis or whatever. But, we've evolved for 100,000 years in Europe and then on. And, you can trace these gene mutations coming all the way from Neanderthal. We've probably all got some called genes for the immune system. That's the biggest thing we got from them. And so we may be alive because of it, So it's kind of, we need to have some humility about, all of this. And we're making a lot of discoveries, we're inching forward. But, somebody's going to discover very much more important things as we go along. We just have to pay attention. And I'm going to get political now. A tank costs $42 million. The F-35 airplane costs $140 million. And it hasn't been certified yet for safety flying. Okay, so, the kind of research we do is for $300,000, something like that.
Let's
And I
get truth in that.
think we as a country need to think about that.
Okay, on that note, thank you so much. Dr. Taki has no introduction, so you can just go ahead and start.
Thank you, thank you. Thank you, John, again. I mean, I have probably heard what you had to say a couple of times in my life, and I never get bored. It's amazing how much I have learned, and I want to absolutely thank you. It's been a wonderful journey together. When I came to interview at UCSF as an aspiring cardiology fellow, I came to UCSF from Boston, and I asked Dr. Crawford at the time, Dr. Crawford, who does prevention at UCSF? Preventive cardiology. And he said, well, Dr. Waters just left. Why don't you go meet with Dr. Kane? And so I headed out to the back of that building at that time and met Dr. Kane, and I was absolutely fascinated. You can see why. And I said, that is where I want to go and train. And it has been a wonderful journey together. We have collaborated. He's been my mentor for more than 10 years.
And we got more papers that need to be published than we published because
we're so busy, yes. And it's been a wonderful discovery, friendship, collaboration, and I can't thank you enough. And we, I think, are always very, as scientists, we're always very reticent to make statements about things, but when we do believe in something, I think we're all very passionate, and that's what I think you see here.
Well, I want to interject one comment, and that is you are a singularly insightful co-investigator. I get ideas from her too.
Well, it's fascinating that these two both have done fellowships in endocrinology, and how that plays into your molecular work. We'd really love to learn more about
So this ties in very well with what I've come to talk to you about today. So I'm going to take off the pedal a little bit on the molecular and show you these novel insights that are coming out very strongly into the cardiology world. And it's very timely as we think of how low with the LDL we can go, that we start exploring other ways of treating our patients, right? There's other mechanisms, there's other things that we need to be thinking about. So I'm going to talk to you about novel therapies for cardiovascular risk reduction, specifically in patients with type 2 diabetes and atherosclerotic cardiovascular disease. There. So as Dr. Kane mentioned in his very graphic graph, when you have diabetes and an MI, your mortality is just dismal, your cardiovascular risk. And because of this, and because new therapies came along that showed significant reductions, in 2018, as a way of informing clinicians about the ways to go about treating these patients with these novel therapies, the American College of Cardiology did something very quickly, which was astounding to me. Which, not that they did it quickly, but how quickly they adopted, right? It usually takes years. So they came out in 2018 with the American College of Cardiology Expert Consensus Decision Pathway. It's a pathway on novel therapies for cardiovascular risk reduction in patients with type 2 diabetes and atherosclerotic cardiovascular disease. And it is very important for people like us that we work with cardiovascular patients, because in our clinics this is absolutely prevalent, much more than in primary care. About at least 50% of our cardiovascular patients are diabetic, and if we extend this into pre-diabetes, who knows how many we have? I mean, maybe 80% or more. And we know that most of the morbidity and mortality in type 2 diabetes comes from macrovascular events. Hence, we as cardiovascular disease specialists need to get involved in optimizing the patient care in people with diabetes. And we kind of don't do that very often. We send them to their primary cares for their diabetes treatment, or the endocrinologist, but in general, cardiologists, we haven't been that involved. So what is new? So these new drugs, one are the SGLT2 inhibitors. I'll explain to you what these are. They have shown to have, it's a sodium glucose transporter type 2 in the kidney that allows for glucose not to be reabsorbed from the tubule, right? So the way the kidney works is how I explain it to the medical student. It's like a mad cleanup lady who throws everything out of the house and then just takes whatever it needs back, right? And that's if I can't define it, I'm not going to pick it up. So that's how toxins and other things that are not recognized just get flushed out, okay? So these, the cardiovascular benefits were initially seen in these two outcome trials, the EMPA-REG outcome and the CANVAS trial, that demonstrated significant reductions in major cardiovascular events. The fun thing about these trials were these drugs were developed to treat diabetic patients, and when they went to the FDA saying, can you please approve this drug, they said, oh, you need to demonstrate or to prove that they're safe from a cardiovascular standpoint. And what they found was, really by accident, was that they improved cardiovascular outcomes. Not only were they not detrimental, they were absolutely beneficial. So they demonstrated a 14% relative risk reduction in the primary composite endpoints of cardiovascular death, MI, or stroke, with a hazard ratio of 0.86, and a 32% reduction in all-cause mortality. The results were driven predominantly by a 38% reduction in cardiovascular death. Then later on, large observational analysis based on administrative claims data, national registries data, electronic medical records of patients treated in current clinical practice have reported similar clinical benefits. So out in the field, this is also kept true. So these decision pathways, so I guess what I wanted to say here was that traditionally, as cardiovascular specialists, we focus on lipid management, antiplatelets, blood pressure control, and overall medications used for glycemic control didn't show any direct cardiovascular benefit.
When it's convenient for you, will you go back to that last slide and do a little bit more explanation on that 38% reduction in, is that all-cause mortality?
Yes, all costs, and mostly driven, you want people to look at that, yes. Yes.
Is that for, who is appropriate to get that?
So these people, I will talk about that, and that is the main point of my talk, is show you who to treat, when to treat, how to treat. And it's mainly based on the very important results from these trials. So I will show you who are the patients who benefit more. Mm-hmm.
So just for the SGLT2 inhibitors with the 1/3 less all-cause mortality, is this one of the medications that you're concerned the right patients aren't getting?
Yes, absolutely. And we need to give them to them. And I will show you how. Or you just need to get this 2018 document and put it on your desk and say, okay, here we go. And hopefully that will be the case. So importantly, the American College of Cardiology, recognizing that we need to work as teams, brought in experts from the American Diabetes Association to co-write with them and have this endorsed. Okay, so these pathways are endorsed by the American Diabetes Association, and I wanted to see if Lisa Duran could come.
Be here today, that our,
Right.
our American Diabetes Association representative, but she can watch your video.
Yes, so Lisa, yes. So this is, they identified 3 key areas where cardiovascular professionals are uniquely positioned to manage these patients, right? So the first 2 we do regularly. We, at least in our practice, we always screen for type 2 diabetes. And sometimes we have trouble with the payers to get hemoglobin A1Cs unless the patient has a history of hyperglycemia. So the code somehow doesn't come up for hemoglobin A1C routinely, but that is something that maybe should be more liberal so that we can actually diagnose these patients earlier. And then to aggressively treat cardiovascular risk factors, I think we do that routinely as well. Where we're missing, and what this consensus decision pathway is about, is incorporating data for newer drugs, anti-hyperglycemic agents, that into routine practice. And what is interesting is that both of these drugs don't seem to act through their glucose lowering effects. It's way beyond that, and actually traditional drugs that similarly reduce or reduce even better glycemic control don't have these effects. So the glucose-centric view is, I think, being challenged, and which is great for us as cardiologists, because we don't want to deal with a glucose-centric view, because we don't want our people to be hypoglycemic. We're always scared of lowering people's blood sugar since we can't follow them so tightly, and we don't feel comfortable there. But the nice thing is that, especially with the SGLT2 inhibitors, they don't need to be titrated, and I'll show you, which is like a cardiologist's dream. A drug that doesn't need titration is like great. And for Rose too. Rose works as a pharmacist in our practice, and she's here. She's going to talk to you a little bit about it. I give her the time. So this is what William Cephalou, who's the chief scientist of the medical and mission officer of the American Diabetes Association, had to say when these guidelines came out. He said, on behalf of the more than 30 million Americans living with diabetes, We are pleased to align and endorse the ACC's decision pathway on novel therapies for people with type 2 diabetes and cardiovascular disease. It's not just a condition of abnormal glucose metabolism, it is also significantly associated with cardiovascular diseases, and the comprehensive data obtained from these major clinical trials over the recent past have demonstrated significant reductions in major cardiovascular events with these two types of medication. And reducing the impact of cardiovascular disease for people with type 2 diabetes is essential to improving quality and length of life. So with that, as I mentioned, these two types of drugs, so let me see, we already talked about that, I'm trying to skip forward. So the guidelines show you why, when, and how to look out for, what to look out for. And it absolutely talks there several times about how we should be collaborating and do interprofessional and multidisciplinary approach. So when I see a patient in my practice with type 2 diabetes who's not on one of these drugs, and I think it's appropriate for them to get it, I call their primary care and I say, hey, I am thinking of putting this patient on this, are you game? And I've gotten two different responses. One type of primary care physician who says, I know nothing about it, I don't feel comfortable, you're gonna have to follow the patient. And I have other types of primary cares who are so excited and they say, yes, let's do it. You know, I'll read the guidelines, we'll do it together. So I think this is work in progress, and I'm very happy that these documents are available to our clinicians, to our pharmacists, to our teams, so that we can work together on this. And you know, this happened also to us when the NOACs came out, the newer anticoagulants. Everybody was freaking out. These new drugs, how do I use them? And slowly we started getting more comfortable, and now it's much easier than warfarin. So I think as we approach these with an open mind and with a learning hat on, we can do it, I think. So what are these trials? So the sodium glucose transporter type 2 inhibitors, they have emerged as important new oral therapies for patients with type 2 diabetes. There's large randomized trials in patients in whom most of them have had established atherosclerotic cardiovascular disease, about 80% of most of the trials, and demonstrated that two drugs in this class, now this is growing as we speak, more trials are coming out, empagliflozin and canagliflozin, reduce major cardiac events and heart failure hospitalization. And they also reduce risk of cardiovascular and all-cause mortality. So, as I mentioned, which patients may benefit? So this was an unexpected result. They found cardiovascular benefits. That's a new study, the DECLARE study, that showed the similar effects for another one of these drug classes, of drugs in this class, dapagliflozin, in patients with established type 2 diabetes and cardiovascular disease, or type 2 diabetes and multiple risk factors. So they took patients with hemoglobin A1C more than 7%, and they randomized to usual care or SGLT2 inhibitors. These drugs are not very effective at reducing hemoglobin A1C. They achieve about a 1% reduction, and hypoglycemia was very infrequent. They saw that in people who are using either insulin or sulfonylurea. So in the expert consensus, you'll see the need to adjust these medications when you start them. So that's something that you might want help from the diabetologist, or to let them know, I'm going to start these drugs, or the patients themselves, if they're used to controlling their glycemias can do it themselves. So I think this is achievable. And they cause glucosuria. So there was a 35% risk reduction in heart failure hospitalization. That has never been seen before. So just a drug that allows you to hospitalize a third of the patient, this should get like in everybody's radar, because that is a huge cost of hospital costs and patient pain. I would say these people get hospitalized frequently.
It comes to mind that this is probably an osmotic diuresis that's helping the failure. Is that the only thing?
There is that, but it's more than that, and I'll show you the possible mechanisms. So, and particularly empagliflozin showed 40% reduction in cardiovascular mortality, and it seems also heart failure related. So all of these effects, when you look at the time to event curves, and I didn't put them here just for time, they diverge very rapidly. So it's not like the other type of drugs that you see effects after a year that the curves diverge. Here, it's almost a week, a month after the curves start diverging. So it is likely an acute hemodynamic effect, like John was saying. So the effects are independent of the dose, like I said, so no titration needed. And there's also a signal, and this is very important, that there's improvement in renal function or preservation of renal function. Initially, some of the studies show a deterioration of renal function and then a gain. So it reminds me of what happened with ACE inhibitors in people, and this is the only other drug in diabetes that I know of that can protect the kidney.
Can I just ask on the heart failure piece, which is something that we haven't yet addressed in this group, with a 35% lower mortality rate, over what time?
I think that it was over 5 years.
Is it appropriate for both preserved ejection fraction? Yeah, okay.
Yeah, so that's the beauty of it. Which to me as a cardiologist has me very excited. We don't have other drugs for patients with heart failure with preserved ejection fraction, and these do beautifully in people with that condition. So
I have had so many cardiologists speak to our groups across the state saying there's nothing we can do for preserved other than tell them to exercise. We don't know what to do. So this is really big news.
this is big news, and I think that's why the guidelines and the pathways came out so early, and they are so specific on what to do so that people really adopt them. And that's why I'm here telling you about them and taking your time to let you know. So these are the possible physiologic effects, sort of the ones that we have seen, very rapid effects and reduction of cardiovascular events, glucosuria with diuretic effect, natriuretic effect, so you get rid of sodium, lower blood pressure because you get rid of sodium, and weight loss as well. And some other off-target effects, one of the ones that they're looking at is inhibition of channel sodium hydrogen co-transporter in the kidney and heart. And there seems to be some tissue resistance to hypoxia. And that's maybe how it's improving the heart failure with preserved ejection fraction, allowing for a more elastic heart. Potential adverse effects, hypoglycemia, you adjust the insulin and sulfonylurea doses. There is some increased risk of amputations in patients with established peripheral vascular disease. That was seen with one drug called canagliflozin. So currently what is endorsed is the other drug, the empagliflozin is the drug of choice for patients with peripheral asthma.
Well, they have all shown some type of, in that select patient population, it's very rare in going through. So it's kind of here, where do you go, what is class effect and what is not? You know, earlier we're showing all the good, where it's saying, oh, is this a class effect? And then now on the side effects, is it just one drug? Or
Uh-huh.
they all having it and going through. So the FDA